So now we have none other than Dr. Partha Biswas, Chairman Scientific Committee. So we welcome him, and he will be speaking on a very important topic: PCR. All is not lost. Still, we have many ways to manage it. Partha.
Thank you very much, sir. And first and foremost, before even I say good morning, I have to apologize to you, all of you, and especially to our chief instructor, for whose IC people have to stand. I feel absolutely saddened and belittled because I could not provide a bigger hall than this. The hall actually was supposed to be twice as this, and but unfortunately we had to make space for the preview room, and that's the preview room that has taken up half the space. So I really apologize, and I'm really sorry about this. However, this is a course that goes on, and Dr. Mathur's course is full of wonderful tips, and we learn from each other through these tips. PCR and something that, when it falls through, then what do we do? Now, when it comes to PCR, the first question when a PCR has occurred, we have to answer is whether I can do a PCC, whether I can fashion it into a posterior capsular rhexis or not. If I can fashion the PCR, the ruptured PC into a rhexis, then the whole management is different. The lens implantation is different. But if I cannot do that, then everything is again different. Now, let us see in this case, there's a large PCR that I have that has occurred. And the nucleus and cortex, a huge chunk is there. Here, of course, it's impossible to convert it into a PCC. So what first I have to do is to compartmentalize this chamber so that the viscoelastic is in between the large nucleus and the cortex, and the PC is down below. And with very, very low parameters, you can take away the nucleus and the cortex very smoothly. Please remember, the moment you feel that vitreous is there, please remove, put in a little more additional viscoelastic, stain, do anterior vitrectomy, all vitreous out of the way, then again you can go ahead and take off wisps of cortical matter if necessary. Here in this case, vitreous has not shown, so we are able to take off the little bit of cortical matter, and you can see that there is. However, please do not rely upon your naked eyes or the microscope that you're using. You have to use triamcinolone. And in this case, we are placing a 3-piece IOL in the sulcus. And you can see that these eyes, you have to be very sure that both the haptics have gone into the sulcus, and then you go ahead and capture it and place in triamcinolone. If there is any amount of vitreous, please do anterior vitrectomy and then only close the case. So triamcinolone works in two ways. It shows you, yes, there's a vitreous tag, or no, there's no vitreous tag. The other thing is, next day, the cornea is much, much more better than if you have not used triamcinolone in the anterior chamber. So definitely to use triamcinolone. Now, a PCR with a central rupture, if there is a central rupture in this PCR, and you can see that everything has gone on well, and it's only at this last stage, maybe due to carelessness, maybe due to any inadvertent movement, a PCR has occurred. And with this PCR, what you need to do is, it's a small one, you need to fill it optimally with viscoelastic, a little bit of cohesive viscoelastic first, and then with methyl cellulose, and then taking the microforceps and making a posterior capsular rhexis out of this. So if there is this neat posterior capsular rhexis, then the whole management is different. You can put in bulky lenses as big as this inside the bag, and that should not have a problem at all. And because this is a stable capsule, and with a stable capsule as this, lens is not going to hurt the capsular bag in any way. But of course, you need to be sure that there is no anterior vitreous. Now again, this is again a large PCR that is there, and with this large PCR, if the nucleus can be removed, it's important to remove as much as possible. And again, suffice it to say that the amount of cortical matter also can be removed extremely well. It is important again to see that the methyl cellulose is being placed every time this goes on, and the bag is nice and stable. Not to remove the phaco needle, of course, while the methyl cellulose gets filled up into the bag, and then only gradual assessment of the posterior capsular rupture has to be made, how much of it is gone, and then going ahead to placing the intraocular lens. So basically, at times where everything is more or less in stable condition, the multi-piece lens is the lens that every lens that you have to implant, whether they be in a multi-piece or a single-piece lens, please have a backup lens. A single-piece lens definitely should have a backup lens. Please have in your library a backup lens, which you can use maybe in the rarest of conditions, but this lens is a very important lens and needs to be used as and when necessary when there is a PCR. Now, a very controversial topic, and I'm going to dwell on this topic: trifocal IOL in PCR. Yes or no? Maybe have a quick show of hands. Trifocal IOL in a PCR, yes or no? Would you or would you not? Niyaz sir. Satanshu sir. Nivian. Okay, yes. So the question is yes, and the question is no as well. So when yes and when no depends upon what is the situation. If the situation is this, that there is the first eye has already had a trifocal and this is the second eye where you have done a PCR. So here is a situation where you can judiciously think of placing the trifocal in the bag if it is possible, but it has to go into the bag. If it cannot go into the bag, please do not put the trifocal. You will have to counsel this patient whether you put a trifocal in a PCR or whether you do not put a trifocal in a PCR and you have placed a single piece. Counseling is most important, and that's post-operative counseling and needs to be done. Now let's go on and see how it is to be done here. So we are placing this trifocal lens in a PCR that has occurred, and as Dr. Prakash also showed very nicely, so it is the folding of the haptic onto the optic that has to be done very well in the anterior chamber, landing it on the iris and never into the capsular bag with a ruptured PC. That is the first trick. The second trick is, again, once one haptic has gone into that place between the posterior capsule and the anterior capsule, then placing the second haptic, again knuckling it so that it just fits in. But of course, most important is the use of triamcinolone. Again, I'll dwell upon the situation where you are trying to put it in the bag and it does not go in. And you see it's sinking down. If it is sinking down, the first haptic, that's the leading haptic, is sinking down. That means what you have done is the bag, the ruptured bag has actually collapsed. And you'll never be able to separate that ruptured bag because vitreous has gone in and you'll not be able to get the vitreous out of the way. So these are situations which are very, very judicious. If you have separated the torn posterior capsule from the anterior capsule, you have that space and you can place the leading haptic in. That's the first thing. If it has gone in, fine, go ahead with the trailing haptic. But if it has not gone in, please take out that lens and replace it with a three-piece lens. Okay, so this is another patient with a PCR, and we have this is a toric lens. Again, with a toric lens, if the rupture has occurred in the toricity, then it is a very difficult proposition. But if it has not, then it is easier. So in this, I was to put a toric lens. I could make a PCC and then place the toric lens in position, and that can be done. So if again a toric lens has to be placed, it has to be placed in position only if you have carved out a PCC or the rupture is 90 degrees opposite the toric markings. So I'll go on to the last two videos of mine, and they are going to be similar to what Dr. Prakash also has shown, but I'm going to show you just one or two small tricks so that, but with this amount of thought that if it can be done well, if you think your expertise is good enough, please do it. But if you think that you're coming too close to the waterfall and things are not going well, just take the lens out and put a 3-piece lens. So this is not for all cases again. So here no vitreous has come, we have a PC rupture, and you can see that's a large PC rupture there, like a hammock. But there we have opened out the posterior capsule from the anterior capsule, and now we are landing the leading haptic over the iris. Very important, over the iris, and the iris should be nicely stretched out. If it's a small pupil lesser than the rhexis, you will not be. Now this is very important. I'm showing it very, very well. That knuckle has to be there, that knuckle, and then it should be just nudged in between the space of the posterior capsule ruptured and the anterior capsule. And again, see where the manipulator is, that's the exact position of the manipulator, so that you're not traumatizing the posterior ruptured capsule anymore. So once this is done, so it goes in and it stays very stable. This one is nearly a 3-year video, and even today we follow the patient up. Patient is very stable. So the last of my videos is again a similar one, in which this is a more difficult rip. It is an eccentric longitudinal rip. So this was a posterior polar cataract, and we were expecting a problem because the first eye done by a colleague of mine had a problem. So again, expect a posterior capsular rupture if the other eye has had a problem, even if it is done elsewhere, because there could have been any difficulty. Now you can see that it's an eccentric rip, okay, but the vitreous is not there, and I'm placing viscoelastic, that blob of viscoelastic, between the tone posterior capsule and the anterior capsule, and then very, very gently in a very stable chamber again landing it there. This is going to be a little more different because you have to twirl around the haptic and the optic, okay. So it has to go in absolutely in visual proper vision, that it has gone into that space between the posterior capsule and the anterior capsule, and then nudging it across, seeing that yes, it is there, and checking also the edge of the anterior capsule. And again, this one is then a little easier, this haptic, the trailing haptic, which was again twirled out, and then it goes into the bag. So again, I would like to put a disclaimer to do it. So we show these cases, but it is not so that I can do this every time I have a PC rupture. Similarly, please assess the situation first, your own abilities first, and then go ahead. But it is always very important to be as safe as possible in a posterior capsular rupture. Thank you very much.
Thank you, Partha. Thank you. So,
thank you, Dr. Partha, for the beautiful videos and the beautiful presentation. One special comment on the trifocal IOLs. When you are putting the trifocal IOLs with the PCR, see, actually, even if you are nudging it properly into the between the anterior and the posterior capsule, see, posterior capsule is not going to support in that way as it's when it's complete. So very important point, because even if you have nudged it very well, you have to make sure that the lens is well centered. The centering is very important, because centering won't happen naturally as we do in the capsular bag. Here, when you have a PCR, you have to center the lens. You have to pull and push the lens right, left, up, down, and bring it to the center, and then put few drops of pilocarpine, constrict the pupil, and then see that your lens is well centered, because the constricting the pupil will definitely hold the lens in position also, and make sure that it will make sure that the lens is well centered.
Thank you, Rajendra. Thank you, Partha.
Thank you very much, sir.
So one important tip you should carry home massive with PCR. Number one thing, do not panic. Do not make havoc in the OT that your patient and staff both are conscious. every anti-segment surgeon should know how to do vitrectomy, anti-vitrectomy. It is very, very important. If you want to learn, we can teach you in SSTC area. We are doing this for last 10 years. Anti-segment, every surgeon should be confident of doing anti-vitrectomy. Number 3 thing, everybody should have a sulcus fixated lens, 3-piece lens in their OT. Along. So these are the few tips, but we are getting short of time. So thank you all, faculty, and thank you all of you for having with us.